Hello and welcome to this online lecture on environmental emergencies hosted by Paramedical Services. The contents of this lecture will include bites and stings from terrestrial creatures such as snakes, spiders, and various types of insects, and aquatic creatures such as jellyfish, cone shells, and blue-ringed octopus. Then we'll cover off on the different types of environmental emergencies such as altitude sickness, diving accidents, drowning, and heat and cold injuries. And then we'll discuss the different types of drug overdoses that you may see in the pre-hospital setting. Australia has some of the most deadliest snakes in the world. These include taipans, brown snakes, tiger snakes, and black snakes. The top 11 most venomous snakes in the world all live in Australia, and on average there's roughly about 3,000 snake bites presented to the emergency department around Australia every year. And roughly about 200 to 500 of these patients require antivenom. What is venom? Venom is made up of multiple different poisonous chemicals, which are called toxins, and many different types of animals have developed a way of injecting venom into other animals to cause a harmful effect. They either use these venoms to gather and kill their food or as a self-defense mechanism against other predators. The different types of venom can result in different types of reactions inside the body. The main ones that we will talk about is the cytotoxic, myotoxic, neurotoxic, and hemotoxic types of venoms. The cytotoxic venoms destroy the body cells. This is usually a localized reaction initially, which causes swelling and a decrease in function of the affected area. There are, however, a few types of species in which envenomation of this type can lead to death, and that's in the viper and cobra species. Generally, this type of envenomation causes severe local or organ-related symptoms such as bleeding, tissue death, swelling, and pain. The myotoxic venoms primarily affect the skeletal muscle tissue. Initially, it affects the ability of the muscles to contract, with paralysis being the main danger at first. Then, as there's widespread destruction of muscle cells, this can release several types of toxins and proteins into the blood, which can cause quite severe tissue damage and kidney damage. 25% of bite victims have severe muscle or kidney damage from this type of venom. Neurotoxic venoms can either inhibit nerve impulses between nerve cells, so stop the transmission from one nerve to another, or they can cause inhibition of nerve impulses from nerve cells to different muscles. And this can result in a varying degree of signs and symptoms such as rapid muscular twitching, convulsions, paralysis, and in extreme cases can cause respiratory arrest and can lead to death. Then hemotoxic types of venoms can either cause coagulation within the blood vessels, so clotting of the blood within those blood vessels, leading to tissue ischemia and organ failure, or it can have an anticoagulant effect where it causes bleeding from vessel wall damage in mucous membranes. Snake bites generally have a mixture of these different types of clinical presentations. So one patient may present with cytotoxic, myotoxic, neurotoxic, and hemotoxic events, all as a result of a single snake bite. In order to measure how dangerous a snake's venom is, snakes are milked for their venom, and then that venom is injected into a test sample, and this can either be mice, rats, or rabbits. Then administering or injecting the smallest possible dose to result in death of 50% of the test sample leads us to what's called the median lethal dose, or the LD50. The lower the number is in the LD50 score rating, the less venom is required to cause death. If we observe the top 25 species in order of their LD50 or lethal dose of 50%, We'll note that the majority of the most poisonous snakes in the world all come from Australia. So it's important for us to have a really good and thorough understanding about venomous snake bites and how to manage them in the pre-hospital setting. Not all snakes are venomous. We also have a large variety of non-venomous snakes. And in order to differentiate between venomous and non-venomous snakes, we observe the shape of their head. Venomous snakes, which contain front fangs, have a more triangular or diamond-shaped head, whereas non-venomous snakes have a rounded head. And you will note the non-venomous snakes have the absence of the front fang puncture marks, whereas venomous snakes have those distinct front fang puncture marks from where their specialized fangs are used to inject venom into their prey. The means in which they do this is firstly by producing venom in a gland in the top of the head, very similar to our salivary glands that we have. The venom is stored within the venom gland and kept there until times of need. When a snake is either striking to protect itself or to kill some prey, when the snake strikes and bites down hard, the fangs, which are usually tucked away in the roof of the mouth, extend forward, and as the snake bites down, the compressor muscle squeezes the venom through the venom gland very rapidly under high pressure along the duct, through a hollow channel within the front fangs and into the prey's tissue. The front fangs are the only fangs that have this hollow channel like a hypodermic needle. However, many venomous snakes also have a smaller rear fang, which is also able to inject some venom along the grooves of the tooth, but it doesn't actually have that hollow channel like the front fangs do. Here are some diagrams of what the snake's different types of teeth or fangs look like. The normal or standard tooth in the snake's jaw is solid. However, the rear tooth or fang has got this groove along it in which venom can slide along the tooth into the wound, and then the front larger fangs have that hollow center running along the length of the fang. So again, once biting down onto prey, it can inject its venom into the tissues. When recognizing the signs and symptoms of a snake bite, you may or may not have fang marks or bite marks present. Often the wound can just look like a scratch on the person's skin. So we can see in the picture on the right hand side over here, there are a few distinct puncture wounds, but also a scratch on the surface of the skin there. Signs and symptoms can vary quite dramatically depending on the type of snake that has caused the bite and what type of venom is predominant in that snake. The general signs and symptoms, however, include things such as a headache, nausea and vomiting, piloerection, where the hairs all stand on edge and it looks like goosebumps on the skin, continued bleeding from the bite site, swelling at the bite site and possibly the affected limb, abdominal pain or chest pain, skeletal muscle pain, muscular twitching and seizures, paralysis, breathing difficulties, and respiratory arrest in severe cases. And just a special note here is that if a child ever states that they've been bitten by a snake or any other animal for that matter, always believe them and take medical precautions. When managing snake bites, it's very important to assess the area for danger, check the response of the patient, and send for help if needed. Assess the airway, breathing, and circulation, and for any deformities. Fix any immediate abnormalities when you're going through and assessing the airway, breathing, and circulation. And as this lecture accommodates those who are doing the Certificate 4 in Healthcare and the Diploma in Healthcare, throughout the presentation, when we talk about managing the airway, breathing, and circulation, manage each of those according to your skill level. So those of you who are doing the Certificate 4 in Healthcare and to be qualified out as an EMT at the end of the day, your airway management would include basic procedures such as using a head tilt chin lift or a jaw thrust. inserting an oropharyngeal airway if necessary. When it comes to managing the breathing, if the patient is hypoventilating, you can use tools such as your bag valve mask to provide assisted ventilations or IPPV. With regards to circulation, when dealing with the patient in shock and trying to manage circulation, obviously is stopping any bleeding that's present and positioning the patient with legs elevated and ensuring that the patient is kept warm. And for those of you who are doing the diploma in paramedicine, airway management could include all of those EMT skills, as well as using things such as nasopharyngeal airways, combi tubes, eye gels, or LMAs to manage the airway. And the same with the breathing, using your BVM to provide IPPV if the patient is hypoventilating or is apneic. And then when we talk about managing the circulation, it may be appropriate, depending on the patient's signs and symptoms, to gain IV access and to administer IV fluids depending on what the blood pressure and the circulation is like, as well as keeping the patient warm and providing possible pain relief appropriate to that of your skill level. Rest, calm, and reassure the patient. Apply a pressure immobilization bandage using the pressure immobilization technique or the PIT technique. This consists of applying a firm, broad compression bandage over the bite site first. If possible, use the plastic wrapping of the bandage to cover the actual bite site to preserve any of the venom that's on the skin, as later on in hospital they may be able to take a swab of this site to help identify the particular type of venom if the patient is unable to recognize the snake. Once covering over the skin with the piece of plastic, apply that firm compression bandage directly over the site. Then take a few more compression bandages and apply the bandage from the most distal point, so fingers or the toes, depending on which limb has been affected, as high up as you can onto that affected limb. So if it was on the leg, we can start, as shown in the diagram on the right, start bandaging from the toes, moving in an upward motion up the leg as high as we can. Then we need to immobilize the limb by any means possible to prevent movement and circulation of the venom. Mark the area on the bandage where the bite site is, so it's easier to identify exactly where to look and cut through bandages once the patient gets to hospital. Monitor the patient's airway, breathing, and circulation continuously and fix any problems as they arise. It's very important not to walk the patient. We've used the pressure immobilization technique as well as immobilizing the limb for a reason. Because snake venom travels through the lymphatic system, which is circulated primarily by muscle movement, we want to prevent any form of muscle movement and thus reduce the lymphatic circulation to try and reduce the spread of venom through the body. It's very important here to note that we will never apply a tourniquet over a snake bite or any other kind of bite area, because, as I've mentioned already, that the venom travels through the lymphatic system, and a tourniquet would not be helpful in this situation. Actually, it would cause more harm to the patient. It's important also not to wash the area or try to extract the venom from the patient, and to transport them as soon as possible to hospitals so they can receive the appropriate care, as well as administering possible antivenoms. Antivenoms are purified antibodies which act as a kind of molecular sponge to soak up the venom or the toxins in the body. The most commonly used animal in the production of antivenoms in Australia is the horse. Sheep, rabbits, and dogs are also currently used to create other different types of antivenoms. And today there are 12 commercially available antivenoms, or also called antivenoms, available in Australia. We have a small mini documentary to show you on how antivenoms are produced in Australia and how they save lives.
Australia is blessed or cursed with really amongst the most venomous animals on the planet. We have technically the most venomous snakes, the most venomous spider, jellyfish, mammal, tick, and the most venomous octopus. These animals are all around us.
And we live on an island, and probably one of the most venomous islands in the world.
We have snakes that, when we test them in the laboratory, we see a level of lethality that outstrips anywhere else in the world.
We have 10 out of 10 of the most toxic land snakes on Earth, and we have about 18 out of 20 snakes with the most toxic venom on Earth, and we love that statistic. The reality is that while our snakes are very dangerous, antivenom is available.
Over my many decades of treating envenoming, of course I've seen many cases of major envenoming where modern treatment facilities have been vital in ensuring that that patient has survived.
Come on then. Okay, there we go, look at that. That's a good amount. My role with BioCSL is predominantly to extract the raw venom from snakes, to milk them and extract the venom, at which point, after a couple of processes, gets sent off to BioCSL, where they do the magic work of turning it into antivenom.
The process of developing antivenom took about 10 years of milking funnel webs and doing venom research on these animals. It does feel really good to be a part of that and to know that those spiders that you milk here every week are actually going to save someone's life.
Yes. At this farm, the species that are involved in antivenom production are rabbits for funnel web spider, sheep for box jellyfish, and horses which produce antivenoms for all the land snakes, plus sea snake, redback spider and stonefish.
If we went back to the earliest days of antivenom development, it involved horses, using horses as the animal to immunise with venom to produce antibody. And that remains the dominant technique throughout the world today.
Antivenoms are made in a living laboratory, in this case a horse.
Technology really hasn't changed over the years. The main change has been the introduction of the apheresis machines which are human plasma collection technology.
In 1930, Australia started producing its first commercial antivenom in a strong collaboration between the Federal Health Department, the Commonwealth Serum Laboratories and the Walter and Eliza Hall Institute associated with the University of Melbourne. We had a very strong interest in producing a full range of products that address the need of the Australian community. Australia has a reputation for some of the highest quality antivenoms in the world and the greatest range.
What's happening today is blood's being drawn from the horse and it passes through this apheresis kit machine, separates red blood cells from plasma. Now the plasma is collected in the bags below, which is used for antivenom production, and the red blood cells are returned back to the horse during the process. This process takes about 3 hours and 10 to 12 litres is collected from each horse.
Here's our equine antivenom production plant. It's about 5 days from go to woe in this process. We produce enough antivenom so that every hospital in Australia, if they need it, has antivenom available. We make 11 different types of antivenom here. Antivenom for black snakes, taipans, death adders, tigers and brown snakes. We also make a polyvalent antivenom, which is those 5 land snakes combined. The sea snake antivenom, a funnel web spider antivenom, a stonefish and a box jellyfish antivenom. The one that gets used the most is redback spider. Redback spiders are found throughout Australia because they have actually adapted to live around humans. So virtually every house will have redback spiders.
Okay, now the release is still potentially dangerous. They've always still got venom, so 1, 2, 3. Thank you, buddy. The Australian Reptile Park is on the front line and has been back since the 1950s of milking snakes and providing this service to BioCSL. I think without that relationship, we would have seen a lot more lives lost in Australia. And it's been a long-standing relationship. We're lucky in Australia that BioCSL makes this product. Bites and stinks account, as you guys will see, for a lot of presentations to the emergency department.
The development of antivenoms in Australia started at the Commonwealth Serum Laboratories in a government laboratory based in Melbourne. So CSL Limited has a long history of involvement in this area,
They developed the venom detection test, they developed the first aid technique that is now standard in Australia and is being looked at in other parts of the world. They've been involved in producing guidelines for doctors on managing envenoming around Australia over the last probably 30 plus years.
So in Australia, the number of snake bites that present to hospitals throughout Australia is about 600 a year. The redback spider envenomation, where people come in with quite extensive amount of pain, what we call local sweating, piloerection, where the hairs stand on end, that's the most common presentation to emergency departments that require antivenom.
The typical person thinks that a snake fang is really pretty large. You know, snakes on a plane, this is an African snake, a gaboon viper, very large fangs. That's kind of a preconception that some people have. But many times, because we've got very toxic snakes in Australia that have, generally speaking, pretty short fangs, then a bite may not particularly be noticed by the patient. But that's a brown snake fang, a leading cause of death from snake bite. So this says that you can have a person who collapses out in the bush or even at home after a snake bite, unaware that the cause of their illness is a snake bite.
The mortality in Australia as a result of snake bite is about 2 to 3 on average a year, and that's been over the past 10 years. In the past, we had a bit of a peak, and we do see that on occasions when you look at the history in terms of mortality as a result of snake bite.
Since the funnelweb's antivenom inception into the hospitals in 1981, we haven't had one single death. But people would still be better off if they knew their first aid procedure.
Snake bite is an enduring challenge. It's not just a challenge for the past, even though we've got antivenoms, even though we've got intensive care units, modern intensive care ambulances, Royal Flying Doctor Service. This doesn't mean you can't die of snake bite in Australia in the 21st century. It doesn't mean you can't die of snake bite in Australia in the 21st century in a capital city like Melbourne. It's happened. So there's an enduring need for education of the general Australian community. So it's only natural that we look to contemporary media to try to get that message out.
The app was developed as a result of us knowing for a fact that people in the community weren't doing the appropriate first aid. So the first stage of the development was to have a hard copy. Obviously now everyone carries smartphones, so this booklet is now in the form of an app and a smartphone. Say someone that you're bushwalking with been bitten by a snake and you're not too sure what to actually sort of do, click on snake bite, bang, first aid comes on, and you know what to actually do, because in a panicky situation, having a reference is really, really good.
To ensure a continued supply of antivenoms for the Australian market, we need a strong relationship with the government. We need reliable venom supplies, healthy donor animals. So those are the things we need to keep antivenoms readily available to Australia.
We're so lucky in Australia that if you're bitten, the antivenom's free. That's a wonderful service from the government. It's a wonderful service from BioCSL that antivenom is available. And without it, we could see hundreds of people die every year rather than a handful.
Here at BioCSL, we feel tremendous pride in being able to be the only supplier of antivenoms for human use in Australia.
We're now going to have a look at different types of spider bites, starting with the funnel web spider. The funnel web spider is a big black spider which can often be confused or look similar to less dangerous big black spiders, including trapdoors and mouse spiders. They're limited to New South Wales, South Queensland and a very small area around Adelaide. They are potentially lethal and they carry a potent neurotoxin which can result in overstimulation of the parasympathetic nervous system. And the most common time that there's presentations of patients to emergency units from funnel web spider bites is during the breeding season in late summer to autumn. Signs and symptoms of funnel web spider bites can include pain at the bite site as well as fang marks at the bite site, and then other inclusions such as overstimulation of the parasympathetic nervous system resulting in headaches, vomiting, abdominal pain, tingling around the mouth, muscle spasms, profuse sweating, increased saliva secretions, bronchial secretions, pulmonary edema, and hypotension and bradycardia. Funnel web spider bites can potentially be lethal without the appropriate interventions and management. The management in the pre-hospital setting includes assessing the DRS ABCD, make sure that the airway is clear of any oral secretions, provide oxygen therapy for these patients and possibly IPPV if pulmonary edema is present. And for paramedics, it's important to establish IV therapy because of the hypotension and the need to administer medications such as atropine. Atropine can be administered by paramedics only or in hospital, and the atropine is used to help combat the bradycardia, hypotension, and to help dry up all of those bronchial and oral secretions, relieving the bronchial secretions and the pulmonary edema. Apply a pressure mobilization bandage to the area. Again, don't walk the patient, try and immobilize the limb and prevent further movement and circulation, and transport these patients ASAP to hospital as they may receive antivenom for this bite. Redback spiders are the most common venomous spider bite in Australia, with approximately 5,000 to 10,000 bites per year. They are found all over Australia and they live in close proximity to humans. Signs and symptoms of a redback spider bite include localized pain at the site of the bite. This usually only develops about 5 to 10 minutes after the bite. Then patients can also experience generalized pain in the joints, the pelvis, the back, abdomen, chest and shoulder, nausea and vomiting, muscle weakness and muscle spasms, and severe sweating, which may be localized to a particular region. Management of a redback spider bite includes assessing the DRS ABCD and managing the airway breathing and circulation appropriately. Apply ice to the site, but do not apply a pressure immobilization bandage to the area, as this can increase the person's pain. Provide the appropriate pain relief and transport these patients to hospital. If the symptoms are significant, they may require the antivenom that's available for redback spider bites. The white tip or white-tailed spider lives all over Australia, and although it has been studied in detail, there has been no definite toxic components found in the venom, so they have not been able to produce an antivenom for this spider bite. Signs and symptoms include a small lump or a bump at the bite site, localized irritation such as a stinging or a burning sensation, localized itchiness, localized swelling, discoloration of the skin, and in some cases patients have reported nausea and vomiting, and in some cases ulceration at the bite site has occurred over time. Management of patients with a white tip or white-tailed spider bite is to assess our DRS ABCD, provide ice to the area, and again no bandage as this is too painful. Provide analgesia appropriate for the patient's pain level, and transport to hospital. In time, some patients may require skin grafts if severe ulceration has occurred. Then in conclusion, for our land-based envenomations, we're going to quickly have a look at tick bites, bee, wasp, and ant stings. While these stings and bites are often painful, they're seldom fatal. Fatalities are usually attributed to anaphylactic reactions as a result of the bite or the sting. Signs and symptoms generally include immediate and intense localized pain, swelling and redness, and minor allergic reactions. But keep an eye out for signs and symptoms of anaphylaxis such as angioneurotic edema, hives, swelling of the tongue and upper airways causing stridor, swelling of the bronchioles and increased mucus production causing wheezing, abdominal pain with insect bites, hypotension, and signs and symptoms of shock. For the management for any one of these, we'll assess our DRS ABCD and manage the airway, breathing, and circulation accordingly. Remove the sting or the insect, For the removal of ticks, ensure that you use a pair of tweezers, pinching the animal by the head and pulling away from the skin, ensuring the whole animal has been removed. And for removal of insect stings, such as a bee sting, you can use a firm object such as a credit card to very quickly swipe across the top of the skin, removing the sting. Do not pinch that sac to try and remove the sting out of the person, as you'll actually inject more of the venom into the tissues. And if you're ever using a pair of tweezers to remove a bee sting, just ensure that you grasp it by the base and not by the sac, where you would again push more of that venom into the person. Once the sting or the insect has been removed, apply a cold compress to the area. If necessary, provide basic analgesia such as Panadol. Oral antihistamines can assist in relieving the signs and symptoms of a localized reaction. However, understand that they do not stop anaphylaxis from developing. So even though some of the mild signs and symptoms of allergic reaction have been relieved, anaphylaxis can still develop. So monitor the patient closely for any signs and symptoms of anaphylaxis. All we need is one sign or symptom of anaphylaxis to be present, and then we should be administering medications such as adrenaline through the EpiPen, or for paramedics, we can actually be drawing up and administering adrenaline IM or IV. And ensure that you follow your protocols for the management of anaphylaxis. We're now going to have a look at the different types of marine envenomations. The first few will all be included in jellyfish stings. Jellyfish have tentacles with stinging cells which eject poison onto the skin on contact, and there are a number of poisonous jellyfish around the coast of Australia. The main ones we'll have a look at is the bluebottle, the box jellyfish, and the Irukandji, which can cause Irukandji Syndrome. Then to conclude this section, we'll discuss the blue ring octopus and cone shell, the signs and symptoms, and how to manage each of these. There are many different types of species in the world's oceans. Approximately about 3,000 different types of jellyfish species have been identified. Many are not poisonous to humans, but the few that are poisonous to humans can range from the simple bluebottle jellyfish sting, which is a mild irritation and not that venomous, to the highly venomous box jellyfish. Starting with the bluebottle jellyfish, these are some of the most common types of jellyfish stings worldwide. The signs and symptoms include immediate pain on contact. Often the tentacles are still present on the skin and result in swollen red welts where the tentacles have come into contact with the skin, as shown in the picture on the right hand side over here. The stings are mild and self-limiting, and they respond very well to first aid measures. The management include assessing the DRS ABC, reassuring the patient, and removing any tentacles, as they will continue to cause injury if they're still in contact with the skin. So ensure that you're wearing a pair of gloves when you do this. Then place the patient under a hot shower for about 20 minutes, as this helps to open up the pores of the skin and wash away any of those stinging cells. If there is no hot shower available though, you can either advise the patient to continue washing the area in the seawater or otherwise use cool water. Mild analgesia such as Panadol is usually sufficient to aid in reducing the pain. Do not apply pressure immobilization bandages to the area, as it can cause more discomfort and more pain, and we don't use vinegar on these types of aquatic stings. The multi-tentacled box jellyfish is found in the tropical waters of Australia, from Queensland around the northern border to Western Australia. Most stings occur during the summer months from November to approximately about April, and as severe envenomation can result in death rather rapidly, it has been associated with at least 67 reported deaths in Australia, the last 12 all being children. Signs and symptoms of the sting usually result in immediate severe pain at the sting sites. There may still be tentacles attached onto the person's skin. They result in large raised red welts where the tentacles have stung the skin. Patients may experience nausea and vomiting and headaches, and with more severe envenomation, sweating, restlessness, and irrational behavior, difficulty in breathing or apnea, and cardiac arrest. Management of box jellyfish stings include assessing the DRS ABCD and manage the airway, breathing, and circulation appropriately. Ensure that any tentacles that are still on the skin are removed, but use gloves to do this. Douse the sting site with vinegar, as vinegar is able to kill off any stinging cells that are still active on the person's skin. However, vinegar does not reduce or relieve the pain of those stings. Apply a cold pack to the area and provide the appropriate pain relief for this patient. Do not use a pressure immobilizing bandage, as this can worsen the patient's condition and increase their pain. Transport them rapidly to hospital, as antivenom is available for box jellyfish stings, and this needs to be administered rapidly. Irukandji syndrome can be caused by Irukandji jellyfish or 10 types of tropical jellyfish that can be found in Australia, and some of those cannot be seen by the naked eye. Irukandji syndrome is a very painful condition, and it's named after an Aboriginal tribe in North Queensland. The initial sting is usually not felt, and there's a short delay in onset of the systemic signs and symptoms. The local signs such as welts, swelling, or dermal markings are minimal or absent initially, in contrast to other types of jellyfish stings. Multiple systemic symptoms develop usually after about 30 minutes to 120 minutes post-sting, and these can include a sense of impending doom, agitation, dysphoria, vomiting, generalized sweating, severe pain in the back, limbs, and abdomen, hypertension, and tachycardia. Severe envenoming manifests within 4 hours, and patients experience cardiogenic shock and pulmonary edema. They may require to be intubated and mechanically ventilated for a time. Despite the severe signs and symptoms of the envenomation, there has been actually very few reported deaths of patients from Irukandji syndrome. 2 of these have been a result of intercerebral bleeding or hemorrhage, which has been uncontrolled as a result of the hypertension. Management of these patients requires assessing DRS, ABCD, and managing the patient's airway, breathing, and circulation according to the signs and symptoms that they're displaying. Ventilation support may be needed. If pulmonary edema occurs, we need to administer IPPV to push the fluids back. Topical treatment of vinegar is a priority in these cases, as it helps to, again, kill off any active stinging cells and prevent further envenomation. Do not use pressure immobilization bandages on these patients, as this can worsen the condition and cause further pain. Provide the appropriate pain management according to the patient's signs and symptoms, and be aware that there is no antivenom available for Irukandji syndrome, but we still need to transport these patients as soon as possible to hospital for further medical care. Other aquatic envenomations include those of the blue-ringed octopus and the cone shell. The blue-ringed octopus is actually a small brown octopus found in the shallow waters around the coast of Australia, but when it's handled or becomes aggressive or defensive, it illuminates these bright blue rings all over its body. The way that the blue-ringed octopus causes envenomation is through a bite from its beak underneath the tentacles. The bite is not particularly painful, and there may be minimal local signs and symptoms. Cone shells, on the other hand, have a barb that they inject into a person, which causes envenomation. There's nearly 500 species of different types of cone shells, the geographic cone shell snail being the most deadly. They're also found around the coast of Australia, and more so in the tropical waters. Envenomation from the blue-ringed octopus and the cone shell both cause progressive descending paralysis, which can occur in approximately 30 minutes. It starts off with tingling or numbness around the lips, general muscle weakness and fatigue, and leading to difficulty in breathing and respiratory arrest. The management of envenomation from a blue-ringed octopus or a cone shell includes assessing the DRS ABCD and managing the airway, breathing, and circulation according to the patient's signs and symptoms. Ventilation support may be required, as this ultimately can lead to respiratory arrest. Provide a pressure immobilization bandage on the affected limb. There is no antivenom for blue-ringed octopus or cone shell. They're just treated symptomatically until the venom works its way through the system. Transport this patient as soon as possible to hospital, as they will require respiratory support. A full recovery is expected within 24 to 48 hours. If cardiac arrest occurs, CPR must be continued for prolonged periods of time and transport these patients to hospital. Often CPR will be continued until the venom has worked its way through the system and patients recover. In this next section, we're going to talk about altitude emergencies. There are 3 conditions related to altitude emergencies, and these include acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. Altitude-related emergencies generally occur above 8,000 feet in the healthy individual. However, people with genetic predisposition or underlying illnesses, sicknesses, or a poor quality of fitness level, altitude emergencies can occur at lower levels than 8,000 feet. At sea level, there are much higher partial pressures of oxygen in the air that we breathe than that of a higher altitude. So as a person rapidly ascends up to higher altitudes above 8,000 feet, the partial pressures of oxygen become less and less, and this means that there's less oxygen available to diffuse into the body during respiration. These 3 different emergencies are primarily a result of the fact that there's not enough oxygen in the air at high altitudes. And if a person ascends up to a high altitude very quickly, it doesn't give the body enough time to change and adapt to the changes of the concentration of oxygen in the air. And therefore, these different types of sicknesses occur. The first of which is acute mountain sickness. This generally occurs from about 8,000 feet upwards. And to put this into an Australian context, the highest peak or mountain in Australia is Mount Kosciuszko in the Snowy Mountain regions, which sits at 2,228 meters above sea level. So it just falls short of the 8,000 feet. However, again, as I mentioned before, is that the very fit, healthy individual may not get acute mountain sickness at these levels, but any patient who has any genetic predisposition, who is also unfit and possibly has any underlying medical condition, may develop signs and symptoms of acute mountain sickness if they ascend up that mountain. Signs and symptoms can be minor, including a headache, nausea, vomiting, fatigue, dizziness, and insomnia at nighttime, whereas more severe signs and symptoms would be all the associated signs and symptoms of hypoxia. For mild cases, rest and an increase of fluid intake, as well as a slight descent, is enough for the body to acclimatize easily and continue. The other 2 altitude emergencies are high altitude cerebral edema and high altitude pulmonary edema. Both of these can occur from any height above 12,000 feet or 3,600 meters above sea level, and generally only occur after exposure to a couple of days at these high altitude levels. Having a look at the high altitude cerebral edema first, the disease process with this occurs because the body is again being exposed to these high altitudes with low amounts of oxygen in the air. The body is hypoxic for a number of days, and generally these people will still be undergoing quite physically demanding conditions. So they'll be hiking and trekking, and their body will still require the same amounts of oxygen, but there isn't actually the same amounts of oxygen in the air around them. So they're in this very mild hypoxic state the whole time. And when the brain doesn't get enough oxygen and we get what's called cerebral hypoxia, the tissue there starts to become irritated and inflamed, and it swells, causing cerebral edema. Now, if there's any swelling inside the brain or inside the cranium, this causes a dramatic increase in pressure inside the cranium or the skull. This becomes a life-threatening emergency, because if there's any swelling on the brain, this can interfere with the normal and vital functions of the brain. It can lead to signs and symptoms such as ataxia, which means an imbalance or uncoordinated walk, nausea, vomiting. It can lead to seizures, decreases in the level of consciousness, and even lead to unconsciousness or a coma. High altitude pulmonary edema can occur at the same time as the high altitude cerebral edema, or these two conditions can occur independently from one another. Now, again, because the body is exposed to these low levels of oxygen and they're generally hypoxic for a number of days, this results in a mass amounts of fluid retention inside the body. Now, because of this excessive fluid buildup in the body, this can result in increased pressures inside the lungs, and fluid leaks out into the lung tissue, causing pulmonary edema. The signs and symptoms of this being shortness of breath, tachypnea, so fast breathing. We might be able to hear rales on the chest when we auscultate with our stethoscope. We have a listen, we'll hear that bubbling through the chest as air sort of passes through that fluid. And the patient would have a tachycardia or fast heartbeat. And if left untreated, this is also a life-threatening emergency. I've explained these three conditions in the most basic form possible. However, if you are interested in looking deeper into these different conditions and you'd like to learn more about the pathophysiology, there are a number of great articles, especially in the GEMS magazine, and also some articles that we'll post up on your student interface, so that you're able to have a look into those if you'd like to. Management for the three different types of altitude sicknesses primarily starts with assessing our DRS ABC, so managing the patient's airway, breathing and circulation accordingly. For mild cases of acute mountain sickness, a descension of approximately 500 to 1,000 meters usually reverses the signs and symptoms. You can administer Panadol to help relieve the headache and give oral fluids. And for more severe cases of AMS, wherever there are signs and symptoms of hypoxia, we need to administer oxygen therapy. The treatment for high altitude cerebral edema and high altitude pulmonary edema would also be to descend immediately, administer oxygen therapy throughout the process. If the patient has pulmonary edema, we need to provide IPPV to push the fluids back. And these patients ultimately would require hyperbaric therapy in a hyperbaric chamber in hospital. Diving is a very common recreational activity in a variety of environments, including caves, lakes, oceans, and rivers all around Australia. And one of the main diving emergencies to be aware of is called decompression illness. Decompression illness, or the bends, is a result of a gas accumulation and bubble formation during diving. It's known as the bends or Cassian's disease. And it can also occur in miners who have been trapped underground for prolonged periods of time where gases have been under pressure. During a dive, where a diver will be breathing compressed gases under pressure, nitrogen dissolves into the blood and is absorbed by the tissues. Then under normal circumstances, when a diver needs to ascend again back to the surface, They go through different pressure zones where they'll stop for a while, take a few minutes to try and allow all that dissolved nitrogen to be breathed out, and then continue to ascend slowly, ensuring that their body is cleared of any nitrogen gases. However, if a diver has to ascend quickly, the nitrogen gases are not able to escape from the body. They group together and find each other in the body's tissues and form nitrogen bubbles. And this can occur in any part of the tissues, the blood, and the lymphatic system. Depending on where the nitrogen bubbles are depends on the typical signs and symptoms you may see. Most commonly, the patient will be experiencing joint pain, swelling, tissue ischemia, and you may see mottling in the skin, shortness of breath, tachypnea, a headache, fatigue, dizziness, paresthesia or pins and needles. It may also result in seizures and unconsciousness. Management of the bends or any diving accident would include conducting your DRS ABC assessment and manage the airway breathing and circulation accordingly. Provide 100% oxygen or IPPV if this is required. Administer the appropriate pain relief for the patient's signs and symptoms, and transport rapidly to hospital for hyperbaric treatment. Hyperbaric oxygen is beneficial as it helps to reduce the bubble sizes, aiding in the release of nitrogen from the body. On the right hand side, this is a stationary hyperbaric chamber that you may find in a hospital, and on the left hand side there's a picture of a portable hyperbaric chamber which is available in rural or very remote settings. The term drowning is defined as a patient experiencing respiratory impairment from submersion or immersion in a liquid. This definition has been published in the Australian Resuscitation Council, as before there was quite a bit of debate about the actual term of drowning, and people used to say that someone only drowned if there was a death associated with submersion or immersion in liquid, and if they didn't die, that it was called a near drowning. But this new definition states that it covers any person experiencing respiratory impairment from submersion or immersion in a liquid. It is, however, defined now as either being a fatal or non-fatal drownings. In Australia, we've got some of the highest cases of fatal drownings in the world. We had 282 drownings in the last 10 years. And over the Christmas period of 2016, the summer holidays, we had double the amount of drowning victims to that of motor vehicle accidents on the roads during that period, which is pretty high and significant. The possible events of drowning, or the sequence of events of drowning, usually starts with an initial immersion of the face or submersion in water. Water enters into the airway or into the stomach. The patient usually tries to cough and possibly even has a laryngospasm, where the larynx and the muscles in the larynx all try to spasm up to prevent fluids entering into the airway. The person generally will try to hold their breath, and most people have the capacity to only hold their breath for about a minute or so. After that, the body vigorously tries to breathe, and this respiratory drive takes over the ability to hold the breath, and then fluid enters into the lungs and into the stomach, so it's aspirated and swallowed. Very shortly after that, the brain becomes hypoxic and the patient loses consciousness and becomes apneic or stops breathing or attempting to breathe. And if this is not reversed by removal of the patient from the water and resuscitative efforts, the patient will go into cardiac arrest. Management of the drowning victim includes the assessment of the DRS ABCD. Remove the victim from the water as soon and as safely as possible, but do not endanger yourself. Conduct a primary assessment, preferably in the lateral position, to aid in removal of fluids from the airway. If the patient is unconscious and not breathing adequately, commence CPR. If the patient is conscious, manage the airway, breathing, and circulation accordingly. Monitor closely in the recovery position. Remove wet clothing, dry and warm the patient, and transport to hospital for further observations and management. In this next section, we're going to have a look at the different heat and cold related illnesses. These include hypothermia and hyperthermia. Hypothermia is when we have a cold or a cooler body core temperature than normal, and hyperthermia is when we have a higher body core temperature than normal. Both of these conditions result in dysfunction of the body's normal processes. And in order to understand how these occur, it's important to understand how the body actually generates and loses heat to the environment. Heat is generated by the body primarily through cellular metabolism or cellular activity. Our body cells are constantly undergoing cellular metabolism while we're awake and we're asleep. They're taking up oxygen and nutrients and glucose, and as a byproduct of cellular respiration, our cells generate heat. And this cellular respiration is what generates our body's core temperature. The normal body core temperature is approximately 36.6 degrees Celsius or 37 degrees Celsius. The more active the cells are, the more heat would be generated from the body. If somebody is sleeping or laying down and is inactive, there's very little heat generated from the body to maintain a core temperature. However, when somebody is very active, for example, doing some kind of sport, using lots of the big muscle groups in the body, because there's such a massive increase in cellular respiration and metabolism, there's also a very big abundance of heat that is created and the core temperature rises up. It's interesting to note here that babies or infants and the elderly don't generate as much heat as young children or adults. This is because their bodies are generally less active, and they also don't have the same amount of muscle mass that is involved in creating heat from cellular respiration. The body has many different ways of releasing heat to the environment. These include evaporation, conduction, convection, and radiation. An example of evaporation is when we do any kind of physical activity and we start to get too hot. The body releases sweat from sweat glands in the skin, and as this sweat evaporates off the body, it results in a decrease in the core temperature. If we were to come into contact with a cooler surface, for example, laying down on a cold tiled floor or jumping into a pool or into the ocean, we're instantly in contact with a cooler surface than the body, and heat is lost rapidly from the body's surface. If cool air is passed over the body, heat can be lost through a process of convection. And the final method is radiation. Often we experience the solar radiation. If you walk outside into the Australian summer sun, you'll instantly feel warmer because of those heat waves and radiation waves coming into contact with your skin. Every single object is able to give off radiation waves, including ourselves. So if we're in an environment that is cooler than our bodies can release radiation or heat waves, and thus heat is lost to the surrounding areas. As humans, we can also take action to either decrease our heat loss by putting on warmer clothing, using heaters, hot water bottles, and drinking warm drinks. Or we can also aid in our heat loss by reducing the amount of clothing we're wearing and also using other things such as fans or air conditioners to help increase the heat loss. So now we have a good understanding of how heat is generated and lost from the body. We're going to move on to looking to the cold and heat related illnesses, starting with hypothermia. Hypothermia is defined as a core body temperature of less than 35 degrees Celsius. There are many different sites that one can use with a thermometer to try and obtain a core body temperature. Using the underarm or the auxiliary method is the least accurate method in obtaining a core body temperature, whereas the rectal method, according to literature, is the most reliable means of assessing the person's core temperature. However, it's time-consuming and invasive, whereas using something such as sublingual or tympanic using an infrared thermometer is the most accurate non-invasive method. Hypothermia can result from being exposed to a cold environment. There can be an increase in heat loss from the individual due to an inactivity or a decrease in heat production, but also due to contact with cold surfaces or not wearing enough clothing in order to retain the heat. This increase in heat loss can also be a result of submersion, which I mentioned earlier is coming into contact with cool water. The body loses heat at a much faster rate than coming into contact with a cold object. True environmental hypothermia can occur in a healthy patient in a cold environment, but secondary types of hypothermia are a result of underlying disorders. For example, a patient collapsing on the ground because of some sort of medical disorder. They are not producing enough heat, they're in contact with cold surfaces and can rapidly become hypothermic. This is quite a common incident in the elderly patient who's collapsed on the floor at home and actually can't get up. They have an inability to move or generate heat and generally are laying on a cold surface like the cold floor and can become hypothermic very quickly. They also don't have as much fat stores, their skin is thinner, and they struggle to maintain heat because of poor thermoregulation mechanisms. This can also be the same in babies. They haven't yet obtained the ability to regulate their own body temperatures, so they can also become cold and lose heat very quickly. Alcohol is also another common cause of hypothermia, as well as drugs, as this can reduce the person's perception of the cold environment around them and also changes in behavioral responses and impaired ability for the body to shiver. The clinical manifestations of hypothermia can be placed into categories of mild, moderate, and severe. The mild signs and symptoms may include signs such as shivering, and this is the body's means to try and generate more heat to overcome the cold body temperature. Pale skin, because the blood is now being redirected away from the skin surface to the core to try and keep the organs nice and warm. The skin may be cold to touch. And when you take a thermometer reading, you'll note that the core body temperature is lower than 35 degrees. It can be impaired coordination, showing signs and symptoms of decreasing level of consciousness, slurred speech, and confusion. The moderate and the severe hypothermic patients generally will have a core body temperature of less than 32 degrees. Once the patient progresses to moderate or severe hypothermia, shivering actually ceases, and this indicates that the body's ability to regulate its temperature or to try and counteract the hypothermia is actually starting to fail. And once shivering ceases, the patient will rapidly start to deteriorate and show other signs and symptoms such as a further decrease in level of consciousness, bradycardia, and hypotension. The principles in the management of hypothermia are quite simple. Firstly, like with any case, we need to assess our DRS ABCD and provide interventions where needed. But the second thing is to start warming the patient. We can do this by removing them from the cold environment that they're in. If the patient has been saturated or their clothing is wet from submersion, remove those wet clothing off the patient's skin and dry the patient. If you have a heater available in the ambulance or in the person's house, turn the heater on to start warming the air around the patient to increase that ambient temperature. If the patient has a good level of consciousness, we can give them some warm oral fluids. Hot chocolate is particularly good because it contains a bit of sugar in it, which also provides fuel for those cells for generating heat energy again. Heat packs are also fantastic. You can apply heat packs under the arms, around the neck and the groin, the hands and the feet. We place the heat packs in these areas because they're next to large vessels, which warms the blood flowing through the areas. Then we can also apply warm blankets and rescue blankets over the patient. Please just keep in mind that rescue blankets have no effect of warming somebody. All that a rescue blanket does is it traps in any heat or cold. So if the patient is cold and wet and you put a rescue blanket around them, they will remain cold and wet. But if the patient is already starting to be rewarmed, the rescue blanket will trap that warmth in and start radiating the heat back onto the patient and actually help to increase their body temperature. Then, conducting all of these things, continuously assess the airway, breathing and circulation while you transport these patients off to hospital. Frostbite is another cold injury which is localized to a body part. It's a result of freezing of the cells in the tissues due to direct contact with extreme cold conditions. In Australia, we do have the extreme cold conditions during winter, and many people flock to the snowy mountains to enjoy the winter sports, and this is quite often where frostbite injuries can be seen. The signs and symptoms can include an initial redness of the tissues and then followed by a blanching, so a whitening of those tissues as the circulation stops flowing through the area. Initially there will be pain, but as this becomes frozen, there may be diminished sensation or complete loss of sensation in the affected area. The affected area will feel very cold to touch and hard, almost like it's frozen. Without immediate intervention, the affected areas can become necrotic and die and become gangrenous, and that can actually spread to other areas as well. So we need to ensure that in the management, we're always following our DRS ABCD, but then we need to start actively rewarming the affected limb. One of the best methods is by submersion in warm water. Please note that the water must never be too hot, as this could cause injury to the tissues. So as the rescuer, you need to test the water first, make sure that it's tolerable, and then you can place the patient's affected limb into that hot water. What we're trying to do here is rewarm the area to the same temperature of the rest of the body, restore perfusion and normal cellular functioning to prevent necrosis and gangrene. Hypothermia is when the body's core temperature rises above 37 degrees Celsius. There are three major types of heat-related conditions or illnesses, which include heat cramps, heat exhaustion, and heat stroke. Heat cramps are the mildest form of heat-related illnesses, and they consist of painful, involuntary muscular cramps or spasms. They usually occur after intense exercise or after profuse sweating in high temperatures or high humidity climates. Through the process of excessive sweating, a lot of electrolytes such as sodium are lost from the body. This then creates an electrolyte imbalance within the body, which causes these painful muscular spasms. The general signs and symptoms can include weakness, nausea, tachycardia, with painful muscular spasms occurring in the skeletal muscles and in the abdomen. Heat exhaustion is more severe than heat cramps, and it results from a loss of water and salt from the body, again through excessive sweating. Heat exhaustion occurs when the body is unable to cool itself down properly through its normal homeostatic mechanisms. And at this point, we still will see that the patient is sweating and has vasodilation in order an attempt to try and cool the body down, but it's just becoming overpowered by the heat in the environment or heat production from the body itself. And if left untreated, this can progress to heat stroke, which is a life-threatening emergency. The same signs and symptoms in heat cramps will also occur in heat exhaustion. However, now with heat exhaustion, we have this further fluid depletion from the body. So the patient will become severely dehydrated and start showing signs and symptoms of hypovolemia. Heat stroke is the most severe form of heat-related illness, and this is a true life-threatening emergency. It occurs when the body's heat-regulating system is overwhelmed by excessive heat. This usually occurs with a core body temperature of 40 degrees Celsius and upwards. The key signs and symptoms of heat stroke include a decreasing level of consciousness, coma, and even seizures. The patient will become hypovolemic, showing signs of symptoms of a decreased blood pressure and tachycardia. The skin will be hot and dry to touch, as sweating has now ceased because the body's heat regulating system is no longer functioning. And if this patient does not receive the appropriate care, this can rapidly deteriorate into a state where the patient undergoes a condition called rhabdomyolysis, where the muscles start to break down and can lead to multiple organ failure. Please keep in mind that both the infants and the elderly struggle with thermoregulation. Their bodies are not well equipped to deal with the changes in temperature, and just like they suffer more readily from the hypothermia, the same as with the higher temperatures or heat-related illnesses. Infants are particularly susceptible to heat changes, and if their body temperature becomes too high, they can suffer from febrile seizures or febrile convulsions. And the elderly patient really suffers from blood pressure changes and cardiovascular disturbances from heat-related illnesses. So just be aware that the infants and elderly are more susceptible to heat and cold-related illnesses, and their bodies do not regulate their temperatures very well. Many of the signs of symptoms of heat exhaustion and heat stroke can be quite similar. But the biggest thing to take note of is a patient who's experiencing heat exhaustion will still have their thermoregulation mechanisms intact. So this patient is going to be sweating. So you might feel that their skin is clammy to touch or diaphoretic. They may also feel cool to touch on the surface of the skin because of the sweating trying to cool the body down. And their core body temperature is going to be less than 40 degrees Celsius. Whereas in heat stroke, the core body temperature is usually 40 degrees Celsius or higher, and the patient's skin is hot and dry because of their inability to sweat. When providing management for heat-related illnesses, the principles are quite simple. We need to remove the patient from the environment and start to cool them down. Firstly, we always assess our DRS ABCD and where necessary, provide interventions. Remove the patient from their environment to a cool or shady area. Where possible, remove any unnecessary clothing. Cool the person down by sponging with water, and make use of a fan or air conditioning to start actively cooling them. Give sips of Staminade or Powerade or some similar kind of electrolyte replacement drink if the patient has a good level of consciousness. And in any instance where the patient is experiencing muscular cramps and spasms, you can assist them by stretching those cramped muscles. And then transport these patients to hospital for further management, constantly assessing their airway, breathing and circulation while en route. In this next section, we'll have a quick discussion about the different types of drug overdoses that you may be presented with. The most common recreational drugs on the market are ice and methamphetamines, cocaine, alcohol, heroin, prescription drugs, ecstasy or MDMA, hallucinogens such as magic mushrooms, LSD or LSA, flakka, and synthetic marijuana, spice, and K2. This is a short list of all the multiple different varieties of drugs that are available in the market. This is always changing as well, as drug producers are constantly trying to stay ahead of the market, so to speak, and are constantly making drugs that are more addictive and have more of the wanted effects. The different types of drugs all have different effects on the body and the system, but we mainly group the different types of drugs into stimulants and depressants, and this is the overall effect that it has on the body, the system, and the central nervous system. Depressant drugs depress the central nervous system and the general functioning of the body, and they can include things such as opioids, which include morphine, opium, and heroin. Alcohol is also a depressant drug, Valium, tricyclic antidepressants, antipsychotic medications, or Xanax. These are all quite common and well-known different types of depressant drugs. The signs and symptoms of overdose from depressant drugs can include pupil dilation, disorientation and delirium, decreasing level of consciousness to unconsciousness, seizures, Also have a decreased respiratory effort with an inability to protect the airway appropriately. So you may hear snoring or gurgling sounds. The patient may be hypoventilating or maybe apneic. There could be cyanosis, vomiting, tachycardia or bradycardia, just depending on what stage of overdose you find the patient in and what medication was used, and hemodynamic instability in hypotension. When managing these cases, conduct the DRS ABCD and treat symptomatically. These patients will most likely require airway management, respiratory support, and cardiovascular support. Transport these patients rapidly to hospital, as in hospital they may be able to test exactly what has been taken and also be able to provide some kind of antidote. Paramedics can administer naloxone in opioid overdoses only, and this will reverse the effects of the opioid overdose. Stimulant drugs include drugs such as ice and methamphetamines, ecstasy and MDMA, flakka, cocaine, GHB or liquid ecstasy, and a multitude of other drugs. The signs and symptoms of an overdose from stimulant drugs include pupil constriction, chest pain, psychosis, disorientation and confusion, severe headaches, seizures, difficulty in breathing, hyperthermia, dehydration, agitation and paranoia, hallucinations, and unconsciousness. The management for a patient suffering a stimulant overdose is conduct a DRS ABCD, manage the airway breathing and circulation appropriately, calm and reassure the patient, and transport to hospital rapidly. In conclusion of this online presentation on environmental emergencies and toxicology, some take-home points to remember is with envenomation, we have 11 of the most venomous snakes here in Australia. Overall, there are a lot of creatures in Australia that can kill you on the land or in the ocean. Although envenomation is rare, it can be fatal, so make sure that you are comfortable with understanding the signs and symptoms of the venomous creatures here, and ensure that you provide the appropriate management for each. The pressure bandage immobilization technique, so the PIB or PIT, is essential for your care of snake bites and certain types of envenomations. And also remember to be aware that many of the different types of envenomations here do have an antivenom available. So ensure that you're always transporting these patients to hospital in order to receive antivenom if needs be. Drowning is a major problem in Australia. It's the third leading cause of accidental death worldwide, and it's one of the highest leading causes of death in childhood. Heat and cold related illnesses can be a result of exposure to the environment, or it can also be a result of an underlying medical condition. So ensure that you conduct thorough, good histories of any patient that you come across with any heat or cold related illnesses, looking out for those underlying medical conditions that can predispose them to these. The management principles for these related illnesses are very simple. If someone is too hot, cool them down and give them oral rehydration fluids and electrolytes. If someone is too cold, warm them up. In regards to drug overdoses and toxicology, drug use is on the rise, and there are new drugs hitting the streets every day which we may not have heard of or be aware of or know what it does to the human body. It's very important for us, where possible, to obtain a good history, do a thorough assessment, and treat these patients symptomatically and transport to hospital rapidly. Thank you for joining us for this online presentation. If you have any further questions, please don't hesitate to contact paramedical services.